Hey everyone, welcome to another video. So in this video, we'll be studying about difficult airway management. So firstly, the topics that are included in second year BSc ATOT, another chapter, difficult airway management devices are indication and contraindication, retrograde intubation, cricothyroidectomy, tracheostomy, stillet and bogies, jet ventilation, and video laryngoscope. So these are the topics that are included in the difficult airway management devices. Okay, before we go into the difficult airway management devices, we'll first have to know what is difficult airway management. So causes of difficult intubation or difficult airway are inability to open the mouth. So some patients might have the defect in opening the mouth. So it could be due to submandibular abscess, that is below the mandible, there is a abscess formation. Then Ludwig angina. So Ludwig angina is a type of bacterial infection that occurs in the floor of the mouth or under the tongue. So the infection might be in the roots of the tongue or due to a mouth injury. So that is Ludwig angina. We'll just write it out. So that is Ludwig angina, a bacterial infection on the floor of the mouth. Moving to the next one, which is retropharyngeal abscess. So retropharyngeal abscess is the abscess that forms when bacteria is grown in lymph nodes that is behind the throat. So that is retropharyngeal abscess. We'll write the meaning of retropharyngeal abscess. So the retropharyngeal abscess, which means a bacterial growth in lymph node behind the throat. Moving to the next one, which is tetanus. Tetanus is an infection which is caused by Clostridium tetani, and it produces toxins that are very painful. That causes very painful muscle contraction. So, in order to which the opening of mouth is very difficult for them. Moving to the next one, which is temporomandibular joint ankylosis. So the ankylosis is nothing but there is stiffening of the joint of the temporomandibular joint. So it is a stiffening. And immobility of the joint. Moving to the next one, which is maxillary trauma. There is a trauma in the maxilla, or in there's one more, which is mandibular trauma that might happen in the mandible. Then there is growth in the oral cavity when there is any abnormal growth or a tumor formation in the oral cavity. So these might be the reasons for inability to open the mouth. Moving to the abnormalities of mandible. Mandible is the lower jaw. So any abnormality in mandible might be a cause for difficult intubation or difficult airway, which is micrognathia, receding chin. That is, the below chin is a little protruded. That is called as receding chin. Then Robin syndrome. That is hypoplastic mandible. Tracheal colon syndrome, mandibulofacial dystosis. Then we have golden hair syndrome, which is hypoplasia. So these are the abnormalities under the mandible, which is micrognathia, Perer Robin syndrome, Treacher Collins syndrome, and golden hair syndrome. Moving to the abnormalities of tongue or macroglossia, Perer Robin syndrome, Down syndrome, and hypothyroidism. So in people with who have Down syndrome, they might have a very large tongue. So that is called as macroglossia. So these large tongue will be very difficult for doing intubation. Moving to the abnormalities of soft palate, we have Robin syndrome, then tracheal colon syndrome, Marfan's syndrome, and achondroplasia. So what is Marfan syndrome? Marfan syndrome is seen to be affecting the connective tissue of the soft palate. Moving to the neck abnormalities, the patient might have a very short neck with a neck circumference of greater than 43 centimeters. Restricted neck movement, that is, people with rheumatoid arthritis might not be able to move their neck sideways, up and down. So that could be a cause for a difficult intubation. Moving to the spondylitis, that is osteoarthritis, disc disease, then clipple fill syndrome. Cervical vertebrae fusion is clipple fill syndrome. These are the restricted neck movements. Moving to the neck trauma, then neck contracture. Post burn or post radiotherapy, there might be a contracture of the neck. Then neck swellings like large thyroid gland or cystic hygroma. So these could be neck swellings. Then diabetes mellitus can also reduce the mobility of atlanto-occipital joint, which could also be a neck abnormality and a cause for difficult intubation. Moving to the laryngeal abnormalities, which could be edema, a tumor formation, or a stenosis, a web, or a fixation of larynx to other structures of the neck. That could be the due to malignancies. Moving to the tracheal abnormalities, stenosis and tumor. So, what is stenosis? Stenosis is nothing but narrowing of the, so there is narrowing of trachea, and there might be a tumor formation, that is stenosis. Into the next one, which is thoraco-abdominal abnormalities, that is near the diaphragm region. There could be kyphosis and prominent chest or large breast. So these could also be a cause for difficult intubation or difficult airway. The abnormality of temporomandibular joint are true ankylosis or false ankylosis. True ankylosis is a stiffening or mobility which is very much prominent. In falls, it could be due to burns or the external trauma or radiations that might have caused a stiffening or immobility of the temporomandibular joint. Moving to the other causes that could be a cause for difficult intubation are protruding teeth or a rabbit teeth, absent denture, that is slippage of laryngoscope. Whenever you're trying to intubate, the laryngoscope might slip in people with who don't have a denture. Then children's anteriorly placed larynx could be one of the cause. Basilar skull fracture. There might be a fracture in the basal region of the skull, which could be a cause for difficult intubation. Then scleroderma is a restricted temporomandibular joint. Then sarcoidosis, which is airway obstruction by lymphoid tissue. Then obesity could also be a reason for difficult airway management, and presence of beard is one of the cause. So, how do you assess a difficult intubation? Whenever you see a patient, how do you get to know whether it's a difficult intubation or not, or is it a difficult airway? So, that is assessed by certain different gradings, and the distance of the neck or the neck movements is being assessed. So, the commonly used grades and parameters for assessment of airway are Mallampati grading. This was given by Shesha. So it was introduced by Sheshagiri Rao Mallampati. Sheshagiri Rao Mallampati. So it was invented by or discovered by Sheshagiri Rao Mallampati. So it was later modified by Samson and Young with four different grades, that is grade 1, grade 2, grade 3, grade 4. We'll be studying about it. So you can observe the different classes, class 1, class 2, class 3, class 4 given here, which determines the Mallampati grading. So this Mallampati grading is done to assess the mouth opening. So the patient is asked to open the mouth as wide as possible and to put their tongue out, so protrude the tongue. Depending on the structure that is being examined, the classification is done. So firstly, in class 1, you can see the faucial pillars over here. So these are the pillars that can be observed in class 1. You can observe hard pillet also, soft pillet also, and uvula also. So in class 1, you can observe all these features, that is facial pillars and hard pillet, soft pillet, uvula, and all are seen. In second class, the base of uvula is seen and a soft pellet is seen. In class 3, only soft pellet is seen, and in class 4, only hard pellet is visible, which is a modified Sampson and Young classification. So that is done with class 1, class 2, class 3, and class 4 of Mallampati grading. So, in according to Mallampati grading, 1 and 2 oral intubation can be done comfortably. In grade 3, with the difficulty, while oral intubation is not at all possible in grade 4. And thyromental distance is another type of assessment of difficult intubation. So thyromental distance is the distance between the thyroid notch to the mental prominence with the fully extended neck. So the patient is said to extend his neck as much as possible, and the distance between the thyroid notch to the mental prominence is taken. So it should usually be greater than 3 finger breadth. So if it is greater than 3 finger breadth, it is easy for intubation. So they have told that normal range is 6.5 or more. 6.5 as a 0 to 6.5 centimeters is difficult laryngoscopy, which is less than 6.0 laryngoscopy may be impossible. Then mentohyoid distance is usually about greater than 5 centimeters, that is 2 finger breadth. Assessment of TM joint function, that is uh, temporomandibular joint functioning. It is done with inter-incisor gap, that is mouth opening is observed. It should at least be 5 centimeters and 2 finger breadth. That is, the patient is said to open his jaw or a mouth, and the temporomandibular joint functioning is checked in order to examine the mouth opening of the patient. Moving to the next one, which is neck movement. So neck movement it should normally have a flexion and extension varying about 165 degree to 90 degree. And Mallampati grading, thyromental distance and neck movements are assessed in every cases. So in almost every intubation cases, they observe Mallampati grading, that is class 1, class 2, class 3 and class 4. Then they observe the thyromental distance, that is the distance between the thyroid notch to the mental prominence. Then they observe the neck movement of the patient also. So these are the three important assessments that are being done in every case. Moving to the grading of difficult laryngoscope given by Kotmak and Lehen. So in grade 1, the glottis is fully visible. You can see that the glottis is fully visible in here. And in grade 2, only posterior glottis is visible. The posterior part of the glottis is visible. So you can observe that in grade 1 the glottis is visible. So these are the glottis that you are seeing. In grade 2 there is only posterior part of the glottis that is seeing, and in grade 3 only epiglottis is being observed. So this is epiglottis that is being observed, and in grade 4 there is no prominent structures that are being visible. So this is the grading of difficult laryngoscopy that is being introduced by Kotmak and Lehen. So, how do you manage a difficult intubation? You have seen the causes of difficult intubation. You have already seen the assessment of it. Now, how do you manage it? So, this management is done with the very beautiful flowchart that is being given in this textbook. We'll go through the flowchart to how to manage the difficult intubation. So, in anticipation of any difficult intubation, the in anticipated cases, the intubation is usually done in awake state itself. So, when the patient is awake itself, they introduce certain nerve blocks or topical anesthesia, and they use some fiber optic bronchoscope to facilitate the intubation. So, that is anticipated difficult intubation. If the awake intubation fails, then surgery is done, but surgery is kept at very as a last resort in order to avoid any complications that might happen. So they either go with regional or an alternative methods, like they perform regional anesthesia, or they do certain alternate methods like mask ventilation or laryngeal mask. So these two are performed in case of intubation is very difficult. If that is also not possible, then surgery is taken as a last resort. They can do tracheostomy. So it is always said to take tracheostomy only if the patient has agreed for tracheostomy. So that completes the anticipated difficult intubation. So you must note there are 3 points under anticipated difficult intubation. So intubation is done in awake state with fiber optic bronchoscope under topical anesthesia or nerve blocks. They either if intubation awake intubation fails, then they perform certain regional anesthesia or alternative methods like mask ventilation and laryngeal mask. And if still it is not possible to do mask ventilation or laryngeal mask ventilation, then they go with tracheostomy as the last resort. That is anticipated difficult intubation. In case of non anticipated difficult intubation, that is patient is be under anesthesia, then ventilation with mask bag and mask is possible. Cannot intubate but can ventilate in this situation. So intubation might not be possible, but with mask and bag the ventilation is possible. So while maintaining ventilation, consider reattempting intubation, called as plan A, maximum 4 times with manipulations such as changing the position of head and neck, cricoid pressure, using different blades of laryngoscope, and use of stillet and bougies, light wands, or intubation with video laryngoscopes, and practice of airway management have revolutionized the practice of intubation. Success rates can be as high as 94 to 99% with video laryngoscope after failed intubation with direct laryngoscope. So in non anticipated difficult intubation, that is, you might have not anticipated the difficult intubation. So in this case the patient is under anesthesia, you can go with ventilation with bag and mask as much as possible. If the ventilation is good and fine, you can reattempt the intubation as plan A. So the plan A should be always reattempting intubation after bag and mask ventilation. So you can try doing intubation for 4 times, maximum of 4 times, by either changing the position of the head or the neck, or giving a cricoid pressure, or using different sizes of blades, and using sizes and types of blades, and also using stillet or bougie, or you can use a intubation with video laryngoscopes. So these could be the different methods that you can adopt under difficult intubation. So that covers plan A. If plan A fails, then the surgery is done, which is under plan B. So the surgery will include LMA if possible, or intubation with the help of intubating laryngeal mask, airway. If plan B also fails, then proceed to plan C, which is revert back to face mask and get surgery done under face mask if emergency, or postpone the case to be done next time as anticipated difficult intubation. If any time situation becomes that mask ventilation also fails, then it might cause laryngeal edema, or excess secretions might be observed. Then after plan C also fails, there is a plan D, whereas ventilating with bag and mask is not possible and cannot intubate and cannot ventilate also. Now since those were just the explanation part, now we'll just go through the actual difficult airway algorithm that is being given here. So how do you manage it is being put into a very small chart over here. So firstly, in difficult intubation, it could be anticipated, that is before the surgery is performed, you can you already know that there is going to be a difficult intubation. The unanticipated is on table, on OT table, the patient might be showing the signs or causes that might be the reason for difficult intubation. So under anticipated, you can manage it with awake intubation, that is the patient is awake, you'll try to intubate it directly. But if it is an unanticipated, there are two ways: either call for immediate help, or do a mask ventilation as much as possible. If in case the mask ventilation is not possible, you'll have these methods. If the mask ventilation is possible, the plan A will be retrying the intubation with changing the head and neck positions, using the external laryngeal manipulations like and bougies, instillets, etc. to do the intubation. If it is successful, then intubation is a successful one. If still it is unsuccessful, there is plan B using of LMA or ILMA. If LMA and ILMA are successful, the intubation has occurred. If it is unsuccessful, then going back to mask ventilation, or you can postpone the surgery. So, if mask ventilation is not possible in unanticipated difficult airway, then we'll retry the mask ventilation with both the hands, and maximum neck extension is done with jaw thrust. If that is successful, intubation is possible. If it is unsuccessful, LMA or ILMA is taken as a resort. If LMA and ILMA are successful, intubation occurs. If it is unsuccessful, we'll go for cricothyroidectomy. If cricothyroidectomy is not possible, we'll have to change it to tracheostomy at the earliest or cancel the case. So these are the different methods that could be used for difficult airway management. So tracheostomy is always taken as a last resort. If the intubation is very much difficult enough where there are many unsuccessful things that are being happening during difficult intubation. So that is a difficult airway algorithm. I hope you can see that. So that's difficult intubation algorithm. So that covers difficult airway management. Moving to the next thing. So airway management and cervical spine injury is one of the thing that is being handled in many of the difficult intubation cases. So here the neck manipulation is very much difficult and life threatening. So the injury to the cervical region is difficult to move the neck of the patient. So every head injury, any injury in the head region should be considered to be a cervical injury in first case. So during manual management of airway, you should manage only the jaw thrust. No neck extension should be done. However, if airway is not manageable by jaw thrust alone, then head tilt and chin lift can be given, because life takes the priority over cervical spine. So, just in case if jaw thrust is not possible for intubation, then the anesthetist might go for head tilting and chin lift, because life is more important than the cervical spine. So intubation should be done with very much concern. So oral intubation with neck stabilization with neck in neutral position should be tried. Neutral in the sense there is no forming of any angle of the neck, and should in neutral position you should first try. If it usually is successful, and neck stabilization can be done manually with hard cervical collars. So the patient is put with the cervical collars, and the intubation is done with so that the neck stays stabilized. As intubation often requires removal of cervical collar, manual stabilization is always preferred. If in case the cervical collar is removed, manual stabilization is done. So an assistant holds the neck in a stabilized position. If still the intubation is unsuccessful, then go for tracheostomy, or LMA or combitube or cricothyroidectomy can be taken as a reserved temporal measure for the cases of difficult intubation and cervical spine injury. When tracheostomy is still not possible due to non-availability of equipment or experienced person, saving measure where time for tracheostomy is not there. So that completes the airway management of cervical spine injury. So we'll just go through the flow chart of cervical injury. So airway management in cervical spine injury is done. It could be even suspected in certain cases. So oral intubation is done usually for cervical spine injury with neck stabilized. So awake intubation is preferred as preserved muscle tone may protect unstable spine. Then a successful is usually seen in cervical spine injury. If it is unsuccessful to intubate in cervical spine injured patient, then we'll go for apnea, non-availability of tracheostomy equipment, or experienced person. So there are three things that you can do if in case tracheostomy equipments are not available, or there isn't any experienced person who can do intubation. So in that cases, there are laryngo LMAs can be used, or combi tube can be used, or cricothyroidectomy or transtrachea jet ventilation is done. Cricothyroidectomy is an invasive procedure. It is usually done as a last resort of non-invasive method, such as LMA. If LMA is not available, then we'll go for cricothyroidectomy because it is an invasive procedure. If unsuccessful and breathing is not possible, then we'll go for tracheostomy. So if all these steps haven't happened, are not possible, then we'll go to tracheostomy as a last resort. So that ends up difficult airway management. We'll be dealing about difficult airway devices in the upcoming video. Thank you.